Ms. Aaron Ball. Okay, go ahead. Oh, yep, go ahead.
My name is Brianna Stein, and my topic is on triangular fibrocartilage complex injuries, or commonly known as TFCC. So just a quick general anatomy. You can see the pictures, what structures are involved. It's on the ulnar side of your wrist. There's also the fovea, which is between your ulnar styloid process and your flexor carpi ulnaris tendon. The TFCC, part of the outside of it is really vascular, where the central part is not. It also is a primary stabilizer of the distal radial ulnar joint, and then a couple of my studies found that it transmits up to almost 20% of our risk load. Classifications for TFCC injuries, it can be categorized into either traumatic or degenerative lesions. So just quickly, the traumatic ones, the first type would be a tear of the central disc, which is the most common. And then the second type would be the ulnar side is torn, and then there may be an ulnar styloid injury. And then the third one is a distal avulsion. And then the fourth type is a radial-sided tear, and then it may or may not have an injury to the radius. And then for degenerative, the first one is just where there's superficial degeneration. And then type 2 is part of type 1, but also there could be some chondromalacia going on. Type 3 is there's degeneration, and then possibly lunate and ulna chondromalacia. And then type 4 involves type 3, but also might have some instability of the ligaments. And then the last type involves type 4, but also there could be some arthritis going on. So common mechanisms of injury. First of all, it occurs in almost like 3 to 10% of athletic injuries. It's common in racket sports, pole vaulting, football, gymnastics, golf, weight training, wrestling, hockey, and water skiing. And as I said before, it's classified as traumatic or degenerative. Typically, the degenerative is seen in like older populations or like gymnastics. And then the mechanism again is whoosh, or there's going to be like an acute collision where there's axial loading, or if someone like falls and then they pronate or they hyperextend their wrist, or their ulna is distracted. Some signs and symptoms would be that there's going to be pain on their ulnar side, and there may or may not be some clicking. Their hand grip is going to be weak. Their wrist is going to be unstable. And again, they're going to have pain with pronation, supination, or extension with axial loading. And then also, it commonly is associated when there is a radius fracture. So for diagnosing it, one of the studies talked about looking at like their ulnar variance. So like if it's more or less, and then it's going to depend on how thick or thin their TFCC is. One of the tests is fovea sign, which was found to be really good, has a good sensitivity rate. It's basically we're just pushing on the fovea, as I talked about before, to see if they have any pain. And then there's also the TFCC compression test, which is again where you're doing an axial load of ulnar deviation. And then you can also use different types of imaging like radiographs, a diagnostic injection, or an MRI. And then for management of it, first you want to look to see how unstable their distal radial ulnar joint is, and then you're going to go from there to see what you're going to do. So either you're going to do conservative, which is typically what you want to do. They'll probably be splinted for up to four weeks, and the studies found that it was almost 60% people would heal from it. And then a few surgeries that my research found was there's arthroscopic debridement, which was just for the type 1 traumatic one, and it's almost always successful. And then there's an arthroscopic repair, which was for the other 3 types of traumatic lesions. And then one of my studies did a reconstruction where they used like the extensor carpi ulnaris tendon, which was found to be really successful in repairing the tear. And then finally, a few of my studies found the wafer procedure, which is basically where they're going to do an arthroscopic decomposition of the joints, and then like debridement of the TFCC. So like again, that's going to depend on how much ulnar variance there is. So like if there's less than 3 millimeters, it said they would just do just a normal wafer procedure, whereas if there's more, they'd have to do the wafer procedure and shorten the ulna. questions?